Firstly, I just wanted to thank Dr. Yu for giving me this opportunity, and I think it's a sort of a great platform to sort of share your findings and sort of learn together. Really wanted to use my time today to provide an approach, like at least the approaches sort of I followed to, but using POCUS from an internal medicine perspective. And I sort of went over the rules that I sort of went by during this rotation, and it's sort of inspired by Dr. Yu's rules and Dr. Marcobrada's rules. So we'll sort of go through that. So first and foremost, this is sort of the rule book that I talked about. We're going to focus on rule number 3. But as always, first rule is always don't trust anyone, and that applies to whatever rotation we do, but specifically to POCUS as well. And the way I sort of saw that playing out, at least during the POCUS rotation, is we get these consults, and like usually sort of overnight, there's some question of maybe somebody had done a POCUS, they found this incidental finding, or this is what they were sort of going off of. But really you want to approach the POCUS rotation and any sort of POCUS consult as any other consult you would do. So don't trust anything that you see or are told. Question everything you see. And our role as a consulting service is to help in decision making, in specifically when it comes to diagnostic uncertainty or treatment therapy. And really, I think it was a really good rotation for me because you really got to at least spend that time to go through taking an unbiased approach to the patient, looking at the chart, understanding the past medical history, the clinical course, the physical examination, and really integrate that all in the POCUS findings. So I just wanted to quickly, just 2 slides on a quick case, and that just tells us that we should really be documenting our studies. But the way I sort of approach this rotation is sometimes if I had a quieter day, I would sort of just read over all of the new admits overnight, and then I noticed there would be sort of times where there's a patient there. They were admitted to medicine overnight. There was something about general malaise, and then there was in the admission note it said POCUS overnight suggested pericardial effusion as a differential for the patient's symptoms. But we looked through, there was no documentation of that POCUS finding in QPAT. There was no report, and there was no images as well. And so I just went and scanned the patient myself. And this was sort of the pericardial effusion that I guess the note was talking about. But the scope of my presentation today is not to talk about pericardial effusions and how to actually differentiate them from fat pads. But really, the point I wanted to make here is, it's really important to document the images that we take and then report on them. So just to bring home the point that don't trust anything that you see or told, especially when you have incidental findings, because I think it changes the management of the patient fully if you do it sort of yourself. Rule number 2 is always eat, as per Dr. Yu's rule. In Dr. Marcobrada's rule, that's respect yourself. Things changed during COVID. It used to be trust Marco as the second rule, but always take the time to eat on the rotation. And then we get to sort of rule number 3, which is sort of the crux of my presentation, which is really respecting the right ventricle. I think right ventricle assessment is a difficult concept because I think through med school or residency, I don't think we're exposed to it as much. It's sort of a difficult problem because often these patients are a bit sicker, or they're sort of just under-recognized as to what's going on with them. And the right ventricle compared to the left ventricle is just not as popular, I feel. And because it's sort of a thinner ventricle, it sort of, you know, can take a little bit, but when it gets worse, the patient really gets into trouble. So in different sort of guidelines I looked at least from the American Society of the Echocardiogram, you know, there's a lot of studies about the right ventricle having an important role in morbidity and mortality in patients. And so I just wanted to go through an assessment from a POCUS perspective of the right ventricle or the right side of the heart, how we sort of approach that and how we can sort of simplify it and make it more recognizable as a problem on the CTU service at least. So these are sort of the components that we'll look at from a POCUS perspective. So first and foremost, the right ventricular size, the RA size, the RV systolic function, and we'll go from there. So the point I sort of wanted to make as well is that a full sort of thorough right ventricle assessment or right-sided assessment is easily done with the 4 views that were taught through our POCUS curriculum anyway. And so it's not something like additional necessarily that we're adding. It's just going through your approach to your 4 views and really just focusing your attention on the right side. And so that's, I think, easily done while you're actually scanning the patient. So I got some of these images from the internet, and but sort of I just wanted to go through all of the 4 views from like an introductory perspective, and sort of some of the advantages and disadvantages of looking specifically at the right side at these views. So first and foremost, our first standard view that we're taught is the parasternal long axis view. Here we can see the RVOT here, the LV, the LA, the descending aorta, and some of the valves here. The advantages for this view specifically from a right side perspective is looking at the RV enlargement. But again, this is not the full RV that we're seeing, but more the RVOT. But sometimes you can look at the size of the right ventricle just in this view itself. But really, I think the disadvantage, and I think this applies to all the views, is it's the RV sort of anatomy is highly variable, and it's hard to just use one sole view for the RV size, basically. But just wanted to point out that in this view, you can look at the RVOT size at least. Let me go down to the parasternal short axis view. Again, we can see the RV here, then you see the LV, you see the papillary muscles. The advantages here are you can see the walls of the RV. Again, from a POCUS perspective, I'm usually not making any sort of major judgments about the walls of the RV. But the other thing you can appreciate is usually the RV on this view is supposed to look more crescent shaped. You do see some, and then the other important thing to note is that we see this concept of septal flattening in systole and diastole, and that's important clinically that we'll get into later as well. Again, disadvantages, like all the other views, cannot be used as a sole RV assessment due to the asymmetric nature of the contraction. And we get to the apical 4-chamber view. This view, I think, is really sort of the most helpful from an RV perspective. Here we can see the RV size. We can look at the RA size, the shape and function of both the RA and the RV. We can measure the RV distance. We can measure the RV area. We can look at your tricuspid valve, which gives us sort of sometimes like a consequence of the RV dilatation. So I think the A4C chamber view is a good view for a sort of a thorough assessment of the RV. And then we get to our subcostal view. Here in the guidelines, at least, people use this more for RV wall thickness, which can sometimes tell us or differentiate acute versus chronic pathologies. We can look for RV wall, RV or RA wall inversion and collapse in situations like cardiac tamponade. We can again look at the RA size here, and then depending on how your tricuspid jet is, we can see if it's parallel to the ultrasound beam, and we can make some deductions that way. But that was just a quick approach. I just wanted to apply these principles to a case and sort of take us through an RV assessment based on the case. So this is a case. We'll have a patient, we'll call her Miss B. She's a 94-year-old woman. She was initially admitted to medicine for like 1 out of 2 gram-negative bacteremia. There's this question of leg cellulitis, and she had an AKI. Relevant past medical history wise, she has a history of left breast cancer. She's status post mastectomy. There was this note about coronary artery disease, but I couldn't really find any details to go along with that. On initial presentation, she'd come in, she was having some minimal oral intake for the last week or so. She had some dyspnea and exertion, some redness and tenderness in her right leg. I think looking at her initial exam and blood work briefly before our consultation, we saw that initially when she came in, she was a bit hypotensive. Otherwise, her vitals were within normal limits. She had a pretty elevated white count, elevated lactate, CRP, and that was elevated. Her creatinine was 188. Hard to know what her baseline was. I think previous notes sort of noted around 109, but she hadn't had any blood work in a couple of years, I believe. And then her blood cultures were positive for 1 out of 2 at least, gram-negative bacteremia and cons as well. Initially, she was treated with broad spectrum antibiotics, initially got fluids. We got called for her, I think about day 9 of her admission. Her clinical course before we saw her, she was hypertensive for about first 3 days in hospital. Her pressures had improved slightly day 3 onwards. The creatinine of 188 initially had gone up to 261 on day 9 when we saw her. Throughout the hospitalization, she was intermittently getting some diuresis and fluids, and because as the team was sort of trying to figure out what the etiology of her AKI. So just looking at her views. So this is again her the parasternal long axis view. And again, I wanted to do more of a focused RV assessment at least. So here you can't see the RV unfortunately as well, or I guess the RVOT as well. But again, you want to try to comment at least on some sort of enlargement, or which we can't really see here. But again, that's sort of the disadvantage, and you have to sort of take the whole picture and all of the views into context. But this was her parasternal long axis view. And then we did her short axis view. So these are 2 different like clips of the same view. Again, can't really see the RV all that well. But I think just sort of focusing at least on the shape of the left ventricle here. I think what I'm concerned a bit about is you can sort of see that there's a bit of a bounce in the septum itself. So there's a bit of flattening in systole or diastole as well. And so I'd say throughout the cardiac cycle, I guess. And so I wanted to talk about something called the D sign. So the D sign is a finding where the left ventricle becomes a D-shaped structure. It's sort of easy to recognize, again, just on a general view that we took, that we take all the time. And it can help us sort of discern if there's any evidence of RV overload, which can cause a shift of the septum towards the left side of the heart. So depending on where it is in the cycle itself, you can make a determination if the RV is overloaded from a pressure perspective or a volume perspective. And so generally, if it's throughout the cardiac cycle, the thought is usually pressure overload related, but there may be a component of volume overload as well. But if you are seeing it mostly in diastole, then we're concerned more about from a volume overload perspective. This is not our patient's image here, but we can see this is sort of a more exaggerated D sign, basically. I think the limitations of this, just recognizing in some conduction delays, particularly left bundle branch block, which our patient didn't have, but is common in our population. Sometimes you can't use this as much, but that was sort of the worry when we saw this patient. So just going back to that, this is sort of the bounce and the flattening is what I'm concerned about. Going to her apical 4-chamber views, again, I tried to get a good apical, so I'm a bit off axis. I'm foreshortening the LA a little bit there. But again, in this view, at least, you can look at the RA size and the RV size, and you can see that the RV size is maybe equivalent or a bit bigger than the LV as well, which is bad news, and we'll talk about that on the next slide. The other thing to note here is that even the RA looks big, but even the intraventricular septum or the intraatrial septum looks like it's going towards the left side as well. So all of that points to me is that the right side of the heart is under duress, likely overloaded from pressure and likely from a volume side. Just some other images here, more for an advanced sort of POCUS views where you put the color on the valve and you can see the tricuspid regurg here as well. But I just wanted to get more into her A4C views again. So one assessment we can make from a right side perspective on the A4C is looking at the right atrial pressure. Again, if the right atria is seeing high pressures, then that's also worrisome sort of for pressure and volume overload as well. And again, the middle clip here is our patient's views. This is her IVC. So we use the IVC and the guidelines say to use the IVC as a marker for your RA pressure, and it works well at the extremes. But the surrogates you can use for RA pressure as well is a dilated right atrium. Sometimes you can look at the volume of the RA, which again, I think is a bit more advanced, but also looking at the interatrial septum, which we talked about. So this is our patient here, and this is sort of bulging that's happening from a clip I found online. But you can see that bulge as well here. Going back to the RV size, again, this is our patient here, and these are some of the images. So usually a normal RV size is less than 2/3 of the LV. A moderately dilated is considered when the RV and LV are equal in size, and the severely dilated is when the RV looks larger than the LV. The other thing to note as well is that sometimes you can use the apex of your view as well to figure out what ventricle is the apex forming ventricle. Usually that's supposed to be the left ventricle, but as the RV size increases, it may displace the left ventricle and occupy the apex. This is sort of an exaggerated view of that, the middle image. And again, this is our patient, where you can clearly see, again, I'm foreshortening the LV a little bit, or the LA a little bit, but you can see that the RV is at least the same size, or if not bigger than the LV here. You can measure the distance as well, and there's some guideline numbers for that, but just visual inspection is also okay. And then the other thing that we can look at is the RV function as well. So we use something called the TAPSE that we're familiar with. But again, really for the POCUS beginners like myself, just learning that the TAPSE you can use a visual assessment for that. So it's a good measure of RV longitudinal function, but it correlates with RV global systolic function, and correlated with advanced studies if you use sort of MRI to calculate the RV ejection fraction. And again, we can see our page. So this is the TAPSE here, and it's about how much your tricuspid annular is moving, or the annulus is moving. But compared to our patient down here, you don't really see that movement as much. So I think putting it all together for our patients specifically, so going back to the RV size, we said it was dilated. We also noted severe TR. Looking at the RA itself, there was bowing of the interatrial septum. And then the other thing to note for our patients specifically is that we saw the septal flattening and bowing through the cardiac cycle, suggesting RV volume and pressure overload. And then we looked at the RV systolic function, and we saw our patient had the decreased TAPSE. So sort of putting it all together for our patient, our concern was that our patient was in RV failure, causing backwards congestion, causing ventricular shift, and that was causing her kidney failure, and that was causing her hypotension. And so we talk about rule number 3, but also rule number 1, don't trust anyone, even the kidneys in this case. So our recommendations were aggressive IV diuresis in order to offload the RV volume overload, and following our patient with serial POCUS. So that was the conclusion of the first case. This was sort of a later into our block, so no clinical resolution yet, but sort of stay tuned for that. Just wanted to bring back quickly to case 2, which is sort of similar story, but Miss L, she's an 87-year-old woman. She was initially admitted to medicine for dyspnea in the setting of acute on chronic anemia. Her relevant past medical history, she had mechanical mitral valve, she's AFib, pacemaker, she had angiodysplasia with chronic anemia. Initial presentation wise, she had progressive dyspnea and exertion. Her initial exam, her pressures were on the lower side. Otherwise, her vitals were within normal limits. Her hemoglobin was 55. Her creatinine was 153, unclear baseline again. She had moderate ascites on the CT abdomen that was done initially. The initial management was blood products, and I think the team had done a fluid Lasix neutral strategy. We were referred for volume assessment on day 2. So looking at her parasternal long axis views, again, in this view, at least, I think we can see, again, focusing just on the RV in this image, we can see that the RVOT just looks a bit bigger. We talk about the rule of thirds, where 1/3 is supposed to be the atria, the other third is supposed to be the LVOT, and then the other third is supposed to be the RVOT. So it looks a bit bigger. And then going back to her short axis view, again, here we can clearly see that bounce, in that D shape that worries us. And then looking at her apical 4-chamber, again, with the mitral valve, her images are not great because of the artifact there. But I think, again, if we look at the ventricles here, you can see the apex forming ventricle it should be the left ventricle, but we can see that the RV is taking over there. It's hard to look at the interatrial septum there at least. Looking at her subcostal views, we can again see a big RV there and a big RA there. And then we can see that she has significant tricuspid regurg as well. So again, putting it all together, for her, we're concerned about severely dilated RV size, severe TR. We're seeing septal flattening or bowing throughout diastole, suggesting RV volume overload. Maybe a bit of the interatrial septum bowing, but harder to say on this on these images at least. And then going back to the RV systolic, can't see the TAPSE as well, but I had other views and it was decreased as well. So sort of applying it all together, I think the other thing to think about in these situations is why do we find the findings? So why is the RV down here at least? And so the thing that we noticed was that that this lady had a previous pacemaker, and you can see that the pacemaker wire is moving a lot, and you know, I don't look at these that much, but Dr. Yu pointed out that the pacemaker wire should not be moving that much. And then we looked at previous echocardiograms, and we noted that there was comments on previous echocardiograms about the pacemaker wire is likely interfering with the valvular apparatus of the tricuspid valve, and that's certainly contributing to her severe TR. Unfortunately, can't do much about that, but just good to look at differentials for the things that we find. So again, going back to rule number 1, don't trust anyone, even the pacemaker. Our recommendations in her case was recommending comprehensive echo and consideration of cardiology consult to assess for detailed tricuspid assessment. In the meantime, we recommend aggressive IV diuresis. And for her, she was diuresed, her kidney function got better, and she actually was discharged. This is just an image I found that sort of puts everything all together. A lot of the research that's been done from an RV or a right heart assessment, at least, is based on pulmonary embolism studies. But I think it still applies to other etiologies for RV dysfunction. And so again, just coming back to it, you know, looking at the size, which we can easily do mainly in our A4C views, looking at the septal motion that we can easily do, looking at tricuspid regurgitation that we can do, and the TAPSE that we can easily do. All the other things are a bit more advanced, but I think it sort of shows us that in the literature, like these are evidence-based things that people do for other conditions. I just wanted to get to rule number 4 really quickly from a POCUS perspective. We should trust Dr. Yu. We can QA studies to Dr. Yu, Dr. Satin, Dr. Barani, but you know, my experience as well, at least during the rotation, you can quickly report your studies. It's very important to report your studies. Dr. Yu will give you very thorough and detailed feedback. And if you guys can see my screen here, he'll give you feedback at midnight on a Saturday as well. So, but you know, just things to note from a rule number 4 perspective. It's really just trust how you scan, trust your positioning. You know, make sure you have an approach to ergonomics, to how you report, and I think it's an incredible and valuable rotation to have for all of these things. And lastly, rule number 5 is make friends. So make friends with the nurses when you're scanning the patients. Don't you know, leave the patient how you found them. Make friends with the patient. I think it's something that we forget, but having that experience where the patient can actually see their pathology, I think is really important, and I think it's really invaluable to the patient as well. But also with the MRP team, there was a lot of sort of back and forth with the MRP team whenever we would have findings, whenever they would consult us. And I think your best friend in the rotation is really clinical context. So putting all of that together really goes a long way. That's all I have so far. Let me know if you guys have any questions.
Hi, Rushil. Can you hear me?
Yeah.
Thanks for putting that together. That was quite informative, especially with the videos. Sorry, the scans. Videos is not the right term. Anyway, my question was about Mrs. B. So that's your first patient.
Yes.
You showed us her left parasternal views, and then you also had the second patient after that, Miss or Mr. L, where you also did the same views. But for B, Mrs. B, you weren't able to see the right ventricle properly. And so that's why you talked about how not to trust that view and we should get other views. But even though L had the same problem, an overloaded ventricle, we could still see some of the RV in the parasternal views. So what was the problem with Mrs. B? Was it, was the issue body habitus, or was it purely she was much more overloaded in comparison to the other patient?
Yeah, I think that's a really good question, Dr. Huda. Like, I didn't compare and contrast the two patients, but I think first and foremost, I think the miss my second patient basically that I presented, I think looked like they had worsening or worse overload, but I think there was just sort of technical reasons, like just the way I had positioned the probe as well, that I think were also contributory between the two images. I don't know, Dr. Yu, if you had anything to add.
Yeah, I think the point Rushil had made about the parasternal long axis view and the right ventricle was mainly that we're not really looking at the right ventricle. We're looking at just a part of the RV, which is actually the outflow tract. So the typical approach is that when we look at the RV outflow tract on the parasternal view, it's more so just hypothesis generation for your other views to look at whether the RV is dilated or not. I don't know if that helps answer the question at all, Dr. Huda.
The other thing that I would mention here, just from an acquisition point of view, is probably where you're actually acquiring the image. This is likely a bit too lateral and might be a little bit too low on the thorax. Because we see the angle of everything is more kind of here, where the angle in your parasternal should be like this. So you're almost halfway between a parasternal and like an apical 3-chamber view. So, and this is a super common problem with patients who have difficult body habitus or can't roll a little bit to their left. You can't get them into a good, like, somewhat decubitus position, and to try and optimize the images. So I think that's also affecting your ability to see some stuff up here.
And then can I ask about that recommendation on serial POCUSing during the course of diuresis? Because I'm starting CTU, and I mean, I don't want to keep paging you guys or telling the team like, oh, daily POCUS follow-up consults, right? So what does that timeline look like when you guys say serial POCUSes?
Yeah, I mean, honestly, like I would be okay with with POCUSing as much as possible. But I think what we had been doing was every like three days or something or so. I don't know, Dr. Yu, if that's.
I think the messaging in that is that sometimes, well, actually often with right ventricular dysfunction and right sided volume overload, you just don't have great clinical parameters to give you an endpoint to the diuresis. There's so much venous capacitance in the splanchnic veins and the leg veins that people can hide it very well. And you might not notice the edema or the ascites or the anasarca, but they are still hemodynamically affected because of the RV overload, resulting in potentially an acute kidney injury or hemodynamic changes with the blood pressure. So even if you start to see improvement with diuresis of the creatinine and the blood pressure, it's hard to know when to really stop the diuresis, right? And so the serial POCUS assessment, especially of the right heart, is potentially quite helpful to give you an endpoint, or I guess a target for diuresis.
Renuka, looks like you have your hand up.
Oh, sorry. Yes. Beautiful presentation, Rushil, and great coaching, Dr. Yu. Really great.
I don't agree with rule 4, by the way, because see rule number 1.
Say again.
Sir, don't trust me all that much, because rule number 1 is still don't trust anyone.
It's a learning. It's a learning. So, so Rushil, I'm going to come to the first case where it is patient B. If you can bring that parasternal view back, which was very interesting, parasternal long axis, perfect here. So in this case and in the second case, when you compare, as Noreen pointed out, that pictures, her images were really very good and appreciative, even to a layman's eyes like us whoever is learning POCUS, who are beginning to learn POCUS. So that patient had more of volume overload, and RV contractility was very good because there was decompression of RV with the tricuspid regurg. But this patient, have you suggested a formal echo to assess the RVSP, and have you suggested a CTPE if this is acute? Because this patient, RV contractility is poor. So it's a pressure and volume overload. And if you can see the LV lumen is literally obliterated. That means LV is not filling. So if you diurese this patient, you may not see that effect as much as you will see in the other patient. In this patient, you'll have to be careful because it's preload dependent as well. So you have to thread more carefully in this patient compared to the other patient. It was just a comment I noticed, that's all. And I think, Jeff, you can add more, or Rushil, you can give some input on that, or anybody who.
Yeah, I think that's fair. So this patient did have a comprehensive echo done with the elevated RVSP. I think like a week prior or something, but I'm not sure. I have to look back about.
I think it was actually maybe a day or two prior to your getting your echo.
I'm not sure about the CT thorax, and I don't remember.
Yeah, the RVSP I think was in the 60s at the time, and then if I recall correctly, when you measured the RVSP, it was actually in the 70s.
Yeah.
So there was actually some dynamic change, and we even thought our RVSP was a bit underestimated due to just to technique. Yeah, so I had a quick peek at the patient status today. I'm not sure if the team members are here to talk about this patient, but she did remain kind of hypotensive throughout all of this. They gave some IV diuresis yesterday, I believe, and she's still a bit hypotensive. And the creatinine is still on the rise. So I think I agree with you. Interestingly, on the comprehensive echo prior to our study, they had talked about an LV function that was decreased in the 30s to 40s, actually. And when we looked at this, I agree with you. This is not a 30s to 40s LV. This is almost an underfilled RV, hyperdynamic per se. I don't know if you have better views. Yeah. So at the very least, to me, looking at the LV here, it's relatively normal in systolic function. So this is a very scary patient where the diuresis can certainly make the hemodynamic worse, even though that hopefully will be the way to go in order to offload that RV and then hopefully improve the preload to the LV.
And can I jump in here just for a sec, Jeff?
Yeah.
This is something that we would see a ton of in the ICU environment. And I think that probably the problem here is that if you assume, in this patient's LV systolic function looks normal, their EF say here, to me that's the same as, you know, a patient whose EF at baseline is 30%, comes into hospital super septic, hyperdynamic, decreased afterload. Their EF, if you looked at it right then and there, might look like it's 50. It's not that their actual systolic function has changed. This LV is probably just being underfilled from the RV dysfunction, if that's the case. And Rushil, can you click forward to the apical 4 here as well? Yeah, and so, I mean, the overall RV systolic function here is like severely reduced. This area is not changing at all. So this is probably a patient that without enhancing their overall RV function, so without, you know, inodilation, you're going to have a very difficult time getting more forward flow and filling that LV, because you will need volume off here, but you're not going to be able to do that safely without a combination of, you know, inodilation, vasopressors, etc. This is, I don't remember the whole story, but I think she was an older patient and comorbid and stuff, and maybe depending on goals of care, this wouldn't be within the scope of her care. My guess is that without that additional hemodynamic support, you're not going to be able to necessarily improve this, because even though the RV, you know, it's dilated, but it's not crazy dilated, but its function is just awful here. And that's actually almost like visually, it almost looks like you're causing a bit of like pseudo LV obstruction kind of at the basal segments, like down here. You almost wonder if you're going to start developing a bit of an LVOT obstruction, because the left side is kind of becoming hyperdynamic.
Yeah, I think I would agree with you. I think this patient, if not for the comorbidities or age or goals of care, really should be heading out of the ICU for some potential inotropic support to help squeeze that RV a little bit more and to allow for a bit of diuresis to improve the overall hemodynamics. And I find that we see this a lot on medicine, on the wards, that go under-recognized until we actually put the probe on the patient and say, oh, shoot, the RV is completely blown up now, and we really need to get that volume off. We might not be able to do it now at this point, and this might be that for this patient.
Great points. So just a history in this patient may be important, leaving apart age, of course. If it happens in a younger patient, history would be the clinical, whether she had a PE or she had a right-sided MI, which is very important in this case. So history has to go that way as well. So whether PE was ruled out in her is important. If they cannot do CT, they should do VQ scan. That's what is important in this patient, because LV is not filling, something is not filling the LV. So nice, great case. Thanks, Michael. Thanks.
Great. Thank you. Are there any other questions or comments from anybody else?
Jeff, do we have a little time to talk about what the deal with that pacemaker wire was? Like, so I don't mean like the technical question. I meant like why you guys felt that that was interfering with the interpretation and the RV function, or sorry, the tricuspid valve functioning.
Yeah, Rushil, do you want to talk about that a little bit? We discussed it a little bit, I think.
Yeah. So just looking at that, like what we worried about, I guess if we look at the middle image here, is that pacemaker wire is sort of interfering with the valve apparatus itself, which again was commented on previous as well. And I think we talked to Dr. Diaz briefly as well, that it's a very common thing that can happen with pacemaker leads, especially at the time of initial like when they actually initially put it in, it can cause perforation, and depending on how old the patient is and their comorbidities, it's unfortunately nothing can be done about it. You just have to sort of treat medically. You wouldn't be able to sort of go in and replace the whole the pacemaker lead in older comorbid patients.
I think the suspicion here is that the when they put in the pacemaker, which was just a few months prior, the wire probably went through a tricuspid valve leaflet. And so what we're seeing here is actually, as a leaflet is opening and closing, it's just dragging the pacemaker wire along with it. And this is really the condition of sort of post pacemaker insertion tricuspid valvular dysfunction, which is relatively common. And as Rushil said, there's very little you can do about it except for fairly major surgery or procedures. But when we have reviewed the echo from just a few months prior, when the pacemaker was inserted, they had already noted the dysfunction. And then there was another echo maybe a month or two later that showed worsening dysfunction of the tricuspid valve and gradual progression of that, and until she came in with florid right-sided heart failure. And I think it was a bit under-recognized because, again, to the point of RV dysfunction being under-recognized in medicine, the echo reports had mentioned everything, but the way it's reported typically doesn't bring up right-sided issues front and center. It usually is embedded within the the right ventricle subheading, or maybe within the tricuspid valve subheading for the RVSP. Often they're not up at the top with the summary. So it's very important for us when we're looking at comprehensive echo reports to really dig into the body of the text a little bit further for something like this.
Thank you.
Are there any other questions or comments from anybody else? Okay, so thank you very much, Rushil, for this excellent presentation. I just disagree with that slide about trusting me. Again, trust no one. But thank you, Rushil, and have a good day, everybody.
Great job, Rushil.